But the very fact that I even have to look at a patient differently because you're going to affect my metric is a problem for me. The patient was meant to be the beneficiary of the system rather than become the pawns of the system. The reason you never went to the doctor was because you didn't want to have to schedule the appointment, wait for it, sit in the waiting room, sit longer, and get 7 minutes with somebody.
It's not unrealistic to see 20 and 30 and 40% increases in premiums just this year. And how is a company supposed to afford that? It's when insurance companies become the stakeholder, they win and the patients lose. Still, number one cost of bankruptcy today is medical debt. It's about the people. Bottom line, it's about the people.
Welcome to Patients Win. Today, we're doing the inaugural episode of Patients Win podcast, and it's my absolute pleasure to be a part of it. Let me start by revealing the two awesome men behind this podcast, the two people who decided to stop looking away. He's a physician who saw patients losing the system he worked for, and a benefits strategist who saw spreadsheets winning and people lost. First, let's meet Dr. Jonathan Bushman. How are you, John?
Doing well. Thanks, Todd.
You bet. Troy, how are you? Troy Reichert.
I'm doing awesome, Todd. How are you today?
We're doing well. You guys excited? Ready to go?
We're ready for it. Absolutely.
All right, let's start with the moment that you guys, each of you knew you could not could not be quiet any longer in terms of what we're going to talk about today.
Absolutely. Yeah, mine actually came from a personal experience of being a physician, but also being a patient. I had hurt my shoulder, been working out, got a little tendonitis in the shoulder, but I was too impatient and too busy to deal with it. And I kept working. And got to the point 8 months into this, I was hurting bad enough on a daily basis, putting my shirt on, trying to wash my hair, that I needed an MRI. I asked one of my buddies down the hall. I'd been in practice 4.5 years. Asked a buddy down the hall, hey, can you order an MRI for my left shoulder? Sure enough, he orders it, and I wait. And I don't get a call from scheduling. I'm working for a health system. I'm thinking, hey, this can't be that hard, right? In the meantime, I get impatient. I say, hey, can you send that order over to the freestanding imaging center? And I'll just go over there and get it done. And it's about 3:45. We send the order over. They call me. Hey, can you be here at 4:15? I'm sure. Yeah, I'll be there. 5:00. I'm rolling out of the place, and at 5:45, I get a personal call from the radiologist telling me the results. That day, I paid $425 cash for that MRI, even though I had insurance. And the next day, I get a call from my employer's offices to schedule this said MRI. And I said, sure, but before we schedule that, can you tell me how much that's going to cost? And they said, oh, well, we don't have that information. You'd have to call the 800 number. Here's the 800 number. So I call the 800 number. Yes, what's your ID? And I'm like, I'm an employee there. Okay, here's my ID. What's the CPT code? Todd, do you know what a CPT code is?
I don't.
Yeah, well, thankfully I'm a doctor and I did, because I would have been like, what do you mean CPT code?
I have a feeling, though, as a patient, I probably should know what it is, right?
No, I mean, why would you?
Most patients don't know what that is, exactly.
Yeah, why would you know what it is? Anyway, it's current procedural terminology, okay? Everything we do in healthcare has a code to it, and there's a billing code, and there's a procedure code, and then there's a diagnosis code. All these codes, right? So they asked me the code. It's going to be a 5-digit code for a left shoulder MRI without contrast. Okay, well, thank goodness I'm sitting at a computer. I Googled it, gave them the code, and they said, okay, give us a moment. 5 minutes later, they come back and said, well, we've run your benefits. By the way, this is a large health system with a self-funded health plan. In other words, the employees are getting monies taken out of their check, as well as the employers giving monies into the health plan to pay for things such as this, right? And they came back and said, your estimated portion is $1,135. I said, $1,135. Okay, estimated. I said, okay, interesting. Okay, can you send that to me in an email? Sure, I'll send it to you in an email. A month later, I resigned. Now, mind you, I was already thinking about resigning and doing what I'm doing today. But that clarity I had in that moment, when my CEO called me in and asked me what my next step was, where am I going, what are you doing? I shared that story with him. And I said, I have complete respect for you, and I think you do a fantastic job at running this organization locally. I really do, and I've enjoyed working with you. You have nothing to do with this. What really hit me too hard and something I can never look past, and I hope you never do as an administrator, is name a day of the week that my money is more important than the patients I serve, their money. Tell me a time where I should care more about my money than theirs, or why I shouldn't care as much about them and their spend as I do myself. I was willing to go out of the system and pay cash for a service that I knew full well my colleagues and coworkers could have provided for me, only at 3 times the expense. So, a few months after that, in January 2019, I launched my direct primary care practice. And since that day, I have never worked for someone other than a patient. They pay my paycheck. They are my boss. I work for them. I'm accountable to them. We work with employers too, but look, they're on the same page. They want healthy employees. So the incentives are right. But that for me was that pivotal moment of saying, I will never look at a patient again differently than I would look at myself as being a patient. And if I'm going to advocate for myself that hard, I'll always advocate for patients that hard.
Troy, you may come at it from a different angle, but what made you say, I can't be quiet about this anymore?
It was very early in my career in the employee benefit space, and it was renewal seasons. And it didn't matter what decisions my clients made, it didn't matter where they went to get their care. They had no effect on the renewal, and that frustrated the daylights out of me. I just couldn't stand it. I was like, "So there's gotta be a different way." And so that put me on a new journey of looking for ways that my clients could have a choice. I'm someone that likes to have a choice. If I've got, a black car and a white car, I wanna have that choice. I don't wanna be like Henry Ford. You can have any color car you want just as long as it's black. And that's what I was in essence telling my clients. And I didn't wanna do that, and so that set me on the journey to discover and find alternatives, ways of actually financing or funding your health care, and that's called health insurance, certainly, but self-funded medical plans is one of those alternative ways and how you design programs. So, it was out of frustration that I had to find something else for my client.
All right, John, you just described a moment ago your personal experience that pushed you to this new endeavor. Is there one particular patient encounter that still bothers you to this day? One that made you question whether the system was actually the problem itself?
So, in the essence of time, I could go on for like hundreds of cases of where this would be, but there was one particular individual. I took care of I took care of her in-laws, I took care of her son, and I'd gotten to know her really well. And she's a really spicy lady, if you know what I mean. She was in her upper 60s. She was a rebel without a cause, would deny anything you tried to do for her, but was happy to see you anyway. Sort of like funny personality. We talk about getting mammograms and nah, I'm not interested. I wouldn't do anything if anything came up. Well, how about a colon? Nah, I wouldn't do anything. No, I'm not interested. Okay, what can I do for you? Nothing. Your blood pressure is 180 over 100. It's okay. That's what it is all the time. I'm like, but that's not normal. That's normal for me. Like, where do I go with this? Well, about 2015, we started instituting what they call quality metrics, which, depending on the physician you may talk to, that sends chills up their spine of what that's supposed to mean or how that's being reported or who's deciding what quality is and how they measure it. But um, among the 5 different metrics that we were looking at the time was colonoscopy rates and mammogram rates. Okay. So they institute this. I've taken care of this lady for, at that point, about 3 or 4 years. And I've always respected the autonomy of my patients. Always. I'm going to give you my best. I'm going to make my best recommendation, regardless of who you are. But you're the one who gets to choose what you do. And I'm going to honor that. I'm going to explain why I think it's important. But I'm going to pat you on the shoulder or give you a hug and tell you I still love you and I still care about you. Let's keep moving. And when you need me, I'm here, right? Well, the day that metric got instituted into my pay period or into my paycheck, it changed the way I felt about her. And it bothered me to the core because I realized she now represented a hickey in my metrics. And she may actually be helping to prevent me getting my full paycheck because now it looks like I'm providing lower quality care because that's how we're measuring it. And I even told her about it. I said, I just think I need to share this with you because I've never had to think like this, but I don't really like it. And I just want you to understand that I still care about you and you're not going to go anywhere and I'm not going to get rid of you as a patient. But the very fact that I even have to look at you differently because you're going to affect my metrics in a negative way is a problem for me. That's a problem for me. I mean, yes, I'm always going to promote your health, but man, that one hit me different. And it wasn't the only one, but in her particular case, it really hit me hard. And
I guess, John, piggybacking on that answer, you kind of touched on it. That really, from that day forward, how did it redefine your definition of what it means to be a doctor?
well, to me, I started questioning quality. And in
Mhm.
healthcare, depending on what circle you're in or who signs your paychecks, they're going to measure quality in different ways. And it's an ongoing debate in healthcare. How do we measure it? Right? Everybody wants to measure it a certain way, and I guarantee you, the ones writing the checks or holding the money will they define what healthcare looks like, and they do it through powers of metrics. How do we measure this? Is it total cost of care? Is it total outcomes? Is it, mammogram screenings? Is it how are we going to do this? And what I started to realize, and especially getting into the model of care that we're in now, is quality is in relationships. Yes, it's in outcomes. Yes, it's in cost, but it's in relationships, and it's what matters to the patient. And I was in a call recently with a bunch of direct care docs. We were talking about, okay, how do we want to measure? How would we define quality for our employers? And I said, why are we defining quality for our employers? Why are we not asking the employers what's most important to them and then measuring ourselves against that? Somehow we're above that? I don't think so. Any other free market out there is going to look at their everyday consumers and say what matters to them. And if they're getting it wrong, they're going to change the way they do business. I don't care if you're in restaurants or entertainment or what. What is it that's going to get these people to keep coming back in the door, keep consuming our product or our services? But healthcare is different. Somehow there's this boardroom upon the boardroom upon the boardroom, controlling the cost of saying no, but we know better in the quality. But it all comes down to the dollars, and this is where Troy and I talk. I mean, this is a daily conversation for us. Is that's what we're trying to vet. We're really trying to dig in to the people that we're working with and how they think and how they're wanting to measure things, because it really truly will help you understand who's their primary subject. My primary subject is
Troy,
patients.
as I said this earlier, Troy, I think what makes this partnership unique and is going to be very, very beneficial for all parties involved going forward is that you come from this from a different angle. Was there a meeting, a renewal call, a spreadsheet where the math just didn't work up, at least to you, that made you decide, hey, something's got to change?
Yeah, absolutely. I was through my career, I eventually became the president of a TPA. And so I was hearing the member services calls, members calling in, patients calling in, and asking my team, "Hey, what about this? What about that?" And I could hear their frustration in their voices. I was going on open enrollment meetings, and I was hearing the questions from, again, members of the health plans. And yeah, these are even self-funded patients. These are self-funded plans, and so they had the right setup for their healthcare finance, but they were still frustrated. And I looked at my org charts, I looked at my financials, and the light bulb came on, and I realized it's still, even in the chair I'm sitting in, it's still only about the money. We forget about the people. And that was like an aha moment, like, we've got to do something to help the people. Yeah, we have got to pay attention to the cost. We have got to pay attention to the financials. We've got to look at all those types of things. But at the end of the day, again, it's about the people. At the end of every spreadsheet, at the end of every one of those numbers is a person, is a family, is a husband, is a wife, is a child. Those are people that are impacted by our decisions, by the plan setup, by what the CFO chooses in his company in terms of healthcare options. So the light bulb was when I recognized, yeah, we got to take care of those things, but it's even more important is the people. How do we take care of the people so that the person can get care and so they don't delay care?
Troy, at what point did you feel like you were actually complicit in a season that or a system that treated the patient as the product? I'm sure when you realized that moment, you felt very, very bad, didn't you?
Oh, It was horrible because, again, I'm contributing to this, in unending nightmare for the patients. We hear stories every day. Jonathan and I are talking to people all the time, whether, again, it's the C-suite from the decision makers to the members, and you hear their frustrations on both sides of the fence. You hear the C-suite saying, "I can't afford this stuff." We're in this season of renewal right now, and, everything that you read about, you see in the newspaper, hear on the news, is about how atrocious these renewals are. And Jonathan and I are just starting to see some of those things come through for others and for our clients. And it's not realistic to see 20 and 30 and 40% increases in premiums just this year. And how is a company supposed to afford that? How's a member supposed to afford that? When they were paying one number, now they're being asked to pay $100 or $200 more a month. That's a minimum what the employee has to pay, and you can multiply that by two or three about what the employer is paying, an increase, just the increase. And so there's tremendous frustration on both sides, and those are two of the key most important stakeholders in the system. It's the employer, the plan, and the patient. And so that's the kind of stuff that we're trying to address.
I know that in any career path, there's always a point where people reach that, hey, there's a little bit of a misunderstanding of the system or the type job that I work in. Um, what point did it come to you where you guys understood the misgivings about the system you were actually a part of, Troy?
Well, when you look at, again, everything that we've become so accustomed to the BUCAs, Blue Cross, United, Aetna, Cigna, Humana, and giving us the renewals, and we just take it on the chin. Whether it's the company that says, "Okay, what's my renewal? It's 12 or 15%. Oh my word, what are my choices? I don't have any, so I got to take it." As a broker, you see these renewals, it's like, what are my options? Jonathan and I are looking at renewals right now, and in the state of Oklahoma, it's like, okay, what are the options? And there's not enough options. There's not many choices that they have, and so they're left with a bad or worse choice. And what kind of choice is that? That's a terrible position to put these folks in. And so we are looking for ways of transforming the system so that the patients have more choices, that the companies have more choices, so that there's more that they can do. They're not just locked into one thing, and there are no choices.
Very well said, John. What do you have to add to that?
Yeah, and I was as you were saying that, Troy, I was thinking just before the time we recorded this, I was on the phone with an employer and going over the renewal with them. Like this, the initial first look at it's 30%. It's $100,000 for a small business. That's
Of
not
additional costs,
of additional.
not their it's additional costs. So where are they gonna come up
Yeah.
with $100,000 as a small company, spread that over 12 months, it's $10,000 a month. Where are they gonna come up with that additional cost?
Yeah, and even the response was like, "Well, we're already kind of stretched as it is, like to even make the current premiums. So like we're going to have to really think this through." And I'm like, "Oh, absolutely." And I've already given some thought to this. I'm going to present some different ideas we can approach this. And everything's on the table, but when everything gets on the table and necessity is the mother of all best inventions, right? It's like, okay, we've really got to think. We've got to dig here. And what we want to do is we always want to make sure that the employees, the people are taken care of, their needs are met, they're taken care of because we don't want to cut them. But how can we rethink or re-envision what that plan looks like so that the people who need it most are taken care of, but also the basic needs are met as well. And I was actually very pleased that this employer actually made a quick turn and said, "Hey, what do you think about X? Well, you think something like that would work?" And I said, "The very fact you're asking me that question makes me feel good because you're already thinking about a fix. You're already thinking through that, and it gives me a lot of hope that we can do that. Now it's education and putting the pieces in place."
All right, we've
Tom, for
discussed.
the last 10 to 12 years, we've basically thrown it on to the employees through higher deductibles, higher copays, higher coinsurance. That's been the way the BUCAs have told us how to do it. Oh, just give them a higher deductible. That's the way we'll cost mitigate this. Just give them a higher coinsurance. Just that's the way we'll deal with these price increases. And yet, again, it's not about the people. Who's actually bearing the cost of that? The employee. And so, okay, they go from a $3,000 deductible to a 5,000. They couldn't afford the 3. How in the world are they gonna afford the 5,000? And so then there's delay of care. They don't go get their care they need because they're afraid of the cost. They can't afford it. Bankruptcy, the still number one cost of bankruptcy today is medical debt. And so we're not helping people in this whole system. Yeah, we're shifting costs, but we're not helping people.
All right, you guys have both described the moment that you realized that was the breaking point for you professionally, things had to change. If people get nothing else out of this podcast, I think the next couple of topics we're going to talk about very, very important. A lot of people stop at frustration. You guys went beyond frustration and came together. You started Pri-Med Healthcare, which is what we're talking about. Tell us, John, how you guys met. You ended up being business partners and co-founders. Obviously, a lot of trust on both ends of that relationship.
Yeah, absolutely. I mentioned I launched my private practice in 2019, and I think it was either the month of or 2 months in. Troy was visiting a local surgery center while he was serving as a TPA president, and he was basically giving a presentation on direct contracting and these high performing health plans. And I was in the audience that night. We exchanged information, and over the next several years, he became the guy that I randomly would call and say, "Hey, what is this? And how does this work?" And I just kind of I think kind of almost inadvertently became his pupil in learning health benefits and saying, "Hey, how does this work?" And I just asked a lot of questions. I think it's funny because a lot of people, my patients or friends locally, will ask me, "How do you know this stuff? Like, how have you learned all this stuff?" And I said, really smart people and a lot of questions. And Troy happens to be one of those smart people, and I happen to be one of the question makers. And so I just continue to ask questions, continue to ask questions. And over time, he's coming to me, starting to ask me a little bit more about the clinical side and like, well, what do you think about this as a physician? Here's an issue that I'm dealing with. And then we had the opportunity to consult together on a larger case. And going through that process together, we're still independent at that point, but going through that process together and the way that I looked at the numbers and the way that I looked at that data and the way that he looked at the data were different, but they were complementary. It's like, hey, this is fun, but it's also enlightening because we're feeding off of each other and growing in our understanding of what's going on. Because I think of healthcare as having two sides, right? I thought I was on the front lines in healthcare as a primary care doctor. The front lines are in benefits. Okay. That's the front side of medicine. It may smell like the back side, as I say, but that's the front side of medicine because if you don't get the health plan correct on the front side, the member experience or the patient experience downstream is not going to be correct, right? You get that chance on the front end of care. And a great example of this is I was on a health share several years ago, not a traditional insurance. I was on a health share. I ended up, only time in my life I ever ended up in the ER. I'll spare you the story on that, but I'll tell you, I got a bill in the mail from the ER physician, colleague of mine locally. The bill was $1,721. Okay, that seems a little bit high. This is cash pay though, right? So I call the business and say, "Hey, I cash pay. I'm looking for a discount." And they go, "Yeah, we can do a 20% discount." And I said, with all due respect, I think that's a relative term. I think we should start with, maybe we started at too high a price. And they go, "That's all we can do." And we don't negotiate. And I said, "Well, that's interesting. Do you know how much Health Choice pays in the state of Oklahoma for that same level of service?" And they said, "No, we don't have access to that information." I said, "Well, I do. It's $252. Do you know how much Medicare pays for that?" "I'm sorry, sir, we don't have access to that information." I said, "It's on CMS.gov. Everyone has access to that. You just got to look it up. Do you know how much Medicare pays for that same service?" She said, "No, I don't know." And I said, $171. In other words, you charged me 1,000% of Medicare, offered me a 20% discount, which is still 8 times that of Medicare, and you're thinking you're doing me a favor. I said, "What is my current balance?" She said, $1,711. It looks like there was a $10 payment made yesterday. And I said, "Yep. And it's on my schedule 29 days from now to pay you $10 more." And I said, "I'll have it paid off in 170 months.
Good.
Now,
Troy, talk about
the point of that is there's the front end and the back end. And they're telling me that because I contacted them on the back end aftercare, that they won't negotiate with me. And you know what? They stood behind it for a long time until they gave in. But on the front side, we negotiate those things. We get them right on the front side, so the member experience isn't like what I had. Of course,
Right.
they're not cash
Right.
pay, but you get the point. They won't negotiate
So
after the fact.
are they still getting your $10 a month?
No, they made a deal pretty quickly, not long after that.
Troy, tell
Yeah.
us about how you guys came together.
Just as Jonathan described, I was out in his town doing a presentation at the surgery center, trying to attract local businesses to our health plan. And so he was in the audience, and we met then. And it's just been, he's asked all these, questions. And I love it because I'm an educator at heart. I wrote 2 books about this stuff because I'm an educator. And so, helping him understand, he's got that clinical mindset, but he's trying to figure out, okay, how do I help these people, not only from the clinical part of things, but from the insurance, from the cost standpoint? And so we've had a lot of conversations over the years. I remember one time he called me up and said, "Hey, I've heard about this, meeting in Denver, and I think this was on a Thursday or Friday before the meeting starts on Monday." And he says, "Hey, do you think I should be in Denver?" And I said, "Absolutely." And so he figured out how to get there. He was only there for like 24 hours, but his eyes got about this big. He was like, "Oh my word, this is the world that I've been asking all these questions about." And I said, "Yeah, you're right." And it was at that point there was another junction in not only our relationship, but in his understanding. And he just he dove in with both feet. So
All right, here's the meat and potatoes of this whole thing. What does your healthcare company do, and how is it rewriting the story, Troy, for patient need?
So Prime Healthcare is about 3 things. Number 1, we are consulting with companies on their plans. We'll do plan evaluations, we'll do benefit audits, we'll do claims analysis. We will help them understand really what they have. Yeah, they've had it, they've bought it, they've paid for it, but they really don't understand what it is. And so we help them understand what it is. And I think the most important part of that, Todd, is that we help them understand that they have choices, that it's not just this thing that they've been paying for the last 10 or 15 or 12, whatever, years, but they have a choice. They have a chance to make a new decision on a new idea. And that's the probably the most important thing that we do at Prime Healthcare. But Jonathan, tell them about the second part with the chief medical officer.
Yeah, so the second piece of what we do is a fractional chief medical advisor. And, large corporations that have, hundreds or thousands of employees oftentimes have a clinical lead over the top of their benefits plan for their health benefits that works alongside the HR leadership or a benefits director. And in many cases, they call them the chief medical officer. Um, but every employer that's spending any decent amount of money needs that clinical voice at the benefits table. They need to be part of that discussion. And and this isn't a cut to every other benefit specialist out there. We just come with a different mindset. We understand what it looks like, not to just have a card that provides a financial coverage. We understand what that means through insurance. But we're talking about how do we actually get care? How do we navigate our patients through the system? And why is it that our costs keep rising? We have no control over this. Oh, and by the way, we have no association or actual link to the care providers, the physicians, or the health systems. The only connection we have is to the company that's taking our dollars and respending it in contracts that they set the rates for. So we're essentially signing the check that, okay, yeah, go spend our money. Bringing that voice to the
Blind
table,
healthcare.
primed healthcare. And we go, look, you need that voice at the table. And we said, we understand we may not be your broker. We understand you don't need us there full time. What we do understand as well is that we provide a value. And that piece, whether that's in your mid-year or just at your renewal or through the year, well, you have the ability to get me on the phone and say, "Hey, I've got a patient, I've got an employee that's struggling to get something done or get somewhere. Can you help me out?" Absolutely, 100%. Employers don't have that. For the most part, they do not have that. And so we're bringing that to the table as well. And we do that in a collaborative spirit. If they're happy with the broker, great relationship, awesome. Let's work alongside you. But guess what? I'm still accountable to the employer. You've hired me. You've paid me. I'm going to be accountable to you. And that means I'll ask the questions. I'll point the things out. I'll help direct traffic where I can. And you can guarantee I'm going to tell you everything that I see. because the more I do that, the more value I'm providing to you as a company.
Name of this new
Todd, one of the
podcast.
things that, the biggest things in the news over the last 6 to 8 months is this whole pre-cert process where, you have doctors sitting behind the scenes doing blanket denials, United Healthcare, Blue Cross, others, and they don't even look at, the pre-certification. Why are they asking for this? And then you have others that are even, non-clinicians, non-doctors who are looking at this stuff saying, "Nah, we're gonna deny that. No, we're not gonna allow that." And it's like, why would you do that? You're trying to override what a doctor's asking for. Now, we all understand, yes, there are bad players out there. There are bad providers out there that are trying to do this stuff just to, pad their pocket, to get RVUs, to increase their income. But that's not the majority of doctors. And so having the chief medical advisor looking at the plan, looking at population health management, helping them understand, hey, this is what we should do as a plan. It brings a whole nother dimension to what that C-suite is looking at and understanding, not only about their benefit plan, but also about their employees and what we need to do for the people.
The podcast name is Patients Win. It's the underlying philosophy of primed healthcare. Glad to have Dr. Jonathan Bushman and Troy Reichert joining us. All right, I'm not smart enough to come up with this, but bedside beats the boardroom. That's kind of a great heading for you guys. We've talked about the difference in your two worlds. Um, what was the first debate you guys had, a doctor versus that benefits guy? And how did you guys eventually, John, find common ground?
Man, you directed at me and I didn't come up with anything. So, actually, Troy and I have talked about this. One of the, if you want to say it, one of the weaknesses of our partnerships are that we just don't really disagree enough. And we see things eye to eye on so many levels, and we understand, hey, that's not always the great. In fact, we actually work with outside advisors that we have hired that ask us all those tough questions and make us debate. Because in general, we're seeing things, at least principally, we see things very much the same. Now, I will say, when he's working independent of me and he's worked alongside other physicians, I do find it interesting that his perspective of what a physician tries to bring into the benefits discussion either fits or doesn't fit. And that's really valuable to me because I find myself actually saying, well, now, hang on, Troy. Like, here's where they're coming from. This is why they're saying that. But they do have to understand that you're in the driver's seat in this particular piece of the conversation. And I get that. So you are representing the employer and they are not in the, in this particular case. But it's interesting because I've been that physician going to a different broker, kind of trying to plead the same sort of case, but not being in the critical position of having the relationship with the employer and the trust from the employer in order to get something done. So I would say that's probably, interestingly, where our where we cross paths sometimes is that it's the perspectives of those conversations with other physicians.
Tell you what,
And
that's
it's not so
called
much,
think.
Todd, disagreements, it's just literally our perspective. I'm looking this way, he's looking this way, and when we come back around, it's like, "Oh, now I got a better." It's actually a broader perspective that he brings to me, that I bring to him, that just really, again, opens up the world to us.
Got to tell you, John, you got it, man. You got a career in this business. That's what you call thinking on your feet. A very good answer on a question you weren't prepared for. All right, we'll start with you, Troy. What was the thing that maybe surprised you, or was there anything that surprised you when you guys initially got together and started looking into the other's world?
Yeah, so back in 2019, the whole DPC, direct primary care movement, was just really getting its legs under them and really getting exposure. So I knew about it, but honestly, I didn't understand it. So, I think the most surprising thing about, meeting Jonathan and learning about him and his perspective was that, he saw the patients and he treated them strategically and thoughtfully without regard to the time he spent. I had gone to the doctor before and they're, 5 minutes and they're gone, 4 minutes, they're gone. And Jonathan wasn't that way, and it intrigued me. It's like, I don't tell me about this. So really, Jonathan was the first DPC that I really got into intimately to understand what his world was like. And I saw patient care in a whole different world. My wife has a DPC membership. She's got a doctor where we live. And yet I compare that doctor to Jonathan every day. And I always tell my wife, yeah, he's okay, but he doesn't measure up to, Dr. Bushman. And so I'm sorry, but, he set the standard way up here for me.
How about you, John?
You have to remind me of the question, Todd.
Just guess. Now, what was it that really surprised you the most when you guys' worlds collided and you got to know more about what the other one was doing?
So I think the biggest thing is number one, and this is testament to Troy as well. Troy is known. I go to national conferences or different meetings or whatever, and consistently I hear, "Oh my gosh, Troy, I love that guy." I'm like, "Yeah, he's been great friend, great business partner. He's got a great reputation, but such a great network of relationships across the country for the various jobs, various responsibilities he's held, and the people that he's worked with." And number one, that's a huge thing in an industry like healthcare, is to have that reputation precede you and it be universally consistent that people respect him. And I think that's number one, that's amazing, but it also sets the bar for me as I kind of got into that space of like, okay, I'm learning personalities, I'm learning what people are doing. And you know what? Sometimes I learn things that aren't so pretty. And we have those conversations too. I'm like, Troy, how is this person doing this and getting away with it? Or how do people not see this? But you know what? That's not our responsibility. We kind of put it under our hat and we move on. And that's business. But there's a lot of stuff that falls outside of the business that both Troy and I think, half our conversations are about those things. And what I mean is the emotional aspect of dealing with clients, um, the social issues, the political issues, all the other things that kind of contribute to healthcare that are meaningful that people wouldn't necessarily know. But the biggest thing Troy brings is just the wealth of knowledge and experience. It's like, okay, that takes time, and to have him as a mentor through that is huge. Um, and really, when I had my light bulb moment, it was to Troy's benefit in that I realized as a primary care doctor, I was doing primary risk management in people's health. And as he was describing what we're doing and we're putting these plans together and we're talking to clients, prospective employers or current employers and saying risk management, we say risk management all the time, right? That's what insurance is. And what I realized was at the core of the message and the core of the idea of risk management, it's the same both in benefits and in the clinic, except for the terminology and except for the focus. One is on finances, one is on health. As a doctor, my focus is on health risk management. In benefits, my focus is on financial risk management. To blend the two, to me, is a beautiful thing because if you don't have one without the other, you don't have completeness in your health plan.
John, you have a blog. Recently, you wrote, "If I speak plainly, some may lose jobs." How do you decide when to confront and when to persuade?
Honestly, I think that comes down to the accountability of the conversation, right? And it comes down to relationships as well. So if I have personally the relationship, the trust, and the accountability to the person in front of me, which is always going to be true for a patient and sometimes going to be true for the employers, at least the ones I haven't yet worked with or trying to get to work with, right? That's where it starts. But once that level of accountability and relationship is there, say for instance, the fractional chief medical advisor, then absolutely they're going to learn. I'm not going to hold something back from them. Uh, where it becomes crucial and challenging is that I think relationships are key regardless of who you are and what business you're in. And I'm respectful of relationships. And you do have to walk on eggshells a little bit with certain information. But that doesn't mean you can't educate. And it also doesn't mean you can't persuade people to learn more or to advocate for themselves. But sometimes you have to teach them how to do that without just, a punch in the gut. right? And,
Yeah.
some people take a more aggressive approach to it. Um, there are certain things that happen behind closed doors, both on the benefit side and in healthcare that I don't feel right about. Um, and I learn them, and I have to learn how do I deal with that. And sometimes it's on the individual basis. I would say in some ways, Todd, I'm finding my voice on LinkedIn a little bit more in social media just to say, hey, this is the way it is, and I'm not directing those efforts or those words at a specific individual or entity, but kind of the system as a whole. Because ultimately, I feel like patients, a good system or a healthcare system, as it was envisioned and created, as far back as you can go, the patient was meant to be the beneficiary of the system, right? And I think about these unfortunate cases of broken families and children in the middle. And you see children who were supposed to be the intended beneficiary of a family system become the pawns in a broken family. And I've seen that in the social aspect of my practice. I've seen also within healthcare, the patients become the pawns of the system rather than the beneficiaries. And that's the whole basis of this conversation. That's the whole reason Patients Win exists as a podcast, is because of those experiences I've had and that Troy has had. And we say, enough is enough. And I'm not going to stand back idle or stand back quiet any longer. I'm going to advocate for those people that I've dedicated my life to. And whether that's children in your world or that's patients in your world, the call to action is you have to speak up.
Very well said. That's the bedside portion of this question. Troy, I'll ask you the boardroom side of it. You operate inside a commercial system, but yet you have personal lines that you draw to keep patients first and make sure that patients win, even if it does cost businesses, right?
Absolutely. And, I think, Todd, one of the most important things that we do in the boardroom with our clients, with our, consulting agreements, is that we help them understand that we are actually redefining the stakeholders. The stakeholders are the patient. The stakeholders are the plan, and the stakeholders are the doctors. When we get those three people, when we get those three stakeholders in the right relationship, good things happen. It's when other people become the stakeholder, like insurance companies, like, pre-cert people, when they put themselves in as the stakeholder and they win and the patients lose, that's when everybody loses. So in our system, we redefine the stakeholders and we make our plans, we make our recommendations based on those three stakeholders. We want to make sure they win because that's who ultimately is, it's all about our care, and the people's care, so.
I think the thing that I'm most impressed with both of you guys is you had good lifestyles, you made good incomes doing what you were doing before you decided to break out and put patients first. What keeps you guys brave? What makes you guys brave to finally step up and take that next step to help your clients?
It's a great question because it's a question that I've brought up to Troy multiple times. I'm like, I don't have to do any of this. My practice has been strong. I've enjoyed practice. I love clinical care. I think ultimately for me, it's yeah, I don't know if burden is the right word. It's sort of burden of knowledge. Like, you can't unsee or unhear what you've seen or heard, and I feel like I do have an accountability to. It's bigger than me. It's ultimately what it comes down to, Todd. It's bigger than me, and I love having the impact and relationships one on one I have with patients. There's nothing that will ever compare to that. But the other thing that I want to have is an impact in groups, employers, and communities. And that's really where this all comes back down to is healthcare is a local thing, right? Majority of your care is going to be on a local level, and we have to maintain the strength of our local healthcare systems or it unravels. And we've seen that in rural healthcare for sure. But I feel like you know, the economics, I've questioned it, you know, does it make sense? It doesn't really matter. I mean, I've been blessed, and like you said, I'm in a good place for that. But the impact I want to make is much greater. And I'm anxious to see over time. I'm kind of, Troy and I have talked about this multiple times as well, but we're very open-minded to if there's an opportunity to make an impact somewhere that we didn't see coming, we want to be prepared to jump on it. We want to be prepared to accelerate right into it and make a lasting impact in that employer, its people, or those communities they serve.
Troy, do you have anything to add?
Absolutely, Todd. It's about the people. Bottom line, it's about the people, and it's the stories of the impact. And to share a couple quick stories, I remember one lady that we had, and again, she was on a unusual health plan that only paid a certain amount for her procedure. And when we, she'd gone out and got prices, and basically the facility only fee, not the doctor, not the anesthesiologist, none of that, just the facility was going to be $35,000. And yeah, okay, she could have figured out a way to mortgage her house or sell a car or something to pay for that. But fortunately, she didn't have to because we found her a direct contract. We found her a doctor. We found a facility. We found her an anesthesiologist that would bundle stuff together. And know what she had to pay ultimately? $15,000. Not 35 just for the facility, but 15 in total. So you don't think that lady's life was changed? Number one, she got the care she needed. Number two, it didn't bankrupt her. She didn't sell her house. She didn't sell her car. So she got something that was affordable. And the second, story I love to share is about the first client that I took self-funded. I love to take them once a year, a six-figure check, and they're not a very big client. They don't have very many employees, but I take them a six-figure check every February after their plan year because that's what they've saved. Because the plan is well managed, the members have engaged, and the company has made good decisions about how they structure their benefit plan. So I return money to them that they didn't have to spend. And so that's a big deal. Again, how can we help the healthcare system? It's about the stakeholders, and that's the patient. It's about the doctors, and we pay them and pay them fairly, pay them quickly, and it's about the plans. So that's the stories, and those are the things that keep me going, and that's what keeps me brave.
You are listening to the inaugural podcast edition of Patients Win, featuring Dr. Jonathan Bushman and Troy Reichert. Okay, guys, let's wrap it up. Got some quick fire questions for you. Quickly paint a day in a picture of what success looks like for you. Describe a day 5 years, 10 years from now, when you know that what we're sitting here talking about, that's in its infancy stages, this movement has worked.
Yeah, for me, it's the patient experience. So what we're trying to do while we're doing it on a small scale, whether that's direct primary care or in the health benefits and the self-funded health plans, when that becomes the norm, the expected, not the exception, that's the world I want to wake up to in 5 years. I want to look around and realize that all the employers in my community are taking advantage of good healthcare and have access to good healthcare, and that their patients, their employees are experiencing healthcare in a much higher quality fashion.
How about you, Troy?
It's very similar in terms of, the plans are seeing lower costs. Again, when you have a well-designed plan, you give people access to care and you do it at the right places, at the right price, at the right time, your prices are gonna be correct. And so there's lower prices than what they're paying today. You're gonna see more control. People and CEOs and patients have more choices. They have control over what they do, where they go, and why they do it, and how much they spend out of pocket. And the members are happy about their benefits. You go take a survey anywhere in the country today, and you just ask a simple question, "Hey, are you happy with your employee benefits?" I bet you 9 out of 10 would be say, "Oh, they're crap," or "They're too expensive." Those are the 2 answers you're gonna get all the time. And I wanna change the answer. I want them to say, "Oh, my benefits are incredible." Yeah, it costs me some money, but it's not, bankrupt to me. I'm able to take care of the mortgage. I'm able to put shoes on my kids' feet. I'm able to pay for the car payments. I'm not putting more money in my, health insurance, premiums than I am paying for my house. And that's what's happening today. And so that's what I see in 5 years is that patients are, in a whole different mindset and have, again, access to care at a reasonable price.
As this thing continues to move forward, we discussed what it will look like 5, 10, 15 years from now. I'm going to ask you, Troy, and maybe it's the same answer you gave a moment ago when you were talking about saving people money, saving that lady $22,000 from $37,000 down to $15,000, still having her car, still having her house. Is that something that in the long-term future, that's what a CFO in this situation would brag about?
Absolutely. When a CFO and a CEO can say, my employees have access to care, they have access to fair prices, and they can get stuff done that they need to without all that other baggage. I mean, again, there are study after study after study showing how people are delaying care because they're afraid of the cost. They don't know what it's going to cost them. So instead of putting themselves or their family at risk financially, they choose not to get care, which is the worst thing for them because, again, it just exacerbates itself. Jonathan knows, if you start the care journey at the right point and catch stuff early, it's a whole lot better on the backside. And so we want to help people get the right care at the right time so they don't compound their problems like that.
For patients that come to you, John, how are they going to feel? And what's your typical day going to look like going forward?
Honestly, Todd, I feel like on the direct care space, what I do on a daily with patients, been doing it for 7 years almost. I mean, it's only continuing to get better in terms of what we're able to bring them, the value we bring them. But it's interesting to me. I'm kind of thinking through this as Troy was giving his answer to you as well. Is that you know I could look at my schedule from this morning, and every single patient I offered something they can't get anywhere else. Whether that was additional time that they wouldn't have gotten, the ability to get into my clinic within 30 minutes of calling, the fact that I handed a medication 90 seconds after I prescribed it to my patient as they walked out the door.
That
As
didn't cost them anything, right?
$4. I mean, hardly anything. Those and then the lab orders and the care plan I gave a patient that was on their way to the ER and happened to call and see if they could get in, and I said, "You swing by here first." We took care of them. We avoided that ER visit. But Todd, this is every day. And while, yes, I've experienced it and I love it and this is my passion, I don't think that there's something special about me that other physicians or PAs or nurse practitioners can't do the same thing. We just have to have more of the system aligned in a financial manner. Like I said, we're on the backside. We've got to get the front side fixed. When the front side gets fixed, the backside is beautiful for patients.
Okay, I've got 2 questions left, one for each of you. Troy, I'm going to start with you. People listen to this podcast. What is the one thing that you hope they get out of this and the transformation that you guys are trying to bring forward?
Every time they listen to us, Todd, I want them to understand one thing, that they have a choice. It is not the normal choices that they've always been given. These are your only choices. You're boxed in. I want them to understand that there's a broad world of choices out there. Now, I'll tell you, it's not always easy. And sometimes those choices are the smoothest. There's some disruption, absolutely. But when they get past that, as the employer, as the patient, as the dependent, once they get used to these types of plans and their choices, they love it because they understand they're going to get care. They're going to go see someone that cares about them, and it's not going to cost them an arm and a leg. So I want them to understand they have a choice.
A choice. John, last question for you. If they take one action after listening to this 50-plus minute podcast, what do you hope that action is?
So the word that comes to my mind is curiosity. I host medical students all the time, and I tell them on day one, your job is to be curious. And if they're not already curious and I can't make them curious, it's hopeless anyway. So yeah, I want patients to be curious because when you're curious, you start thinking. That's what everyone has to start doing again is thinking and recognizing that there are solutions, there are answers, there are options. Like you said, Troy, there's choices, but we have to stimulate the curiosity in people to say there's got to be a better way. There's no accident. This is what's behind me because this is my mantra. Okay. I just don't stop asking. And I want patients to do that, because when they start asking those questions, they get really, really curious. They dig in, and guess what? They end up in better health. They end up more engaged. They end up saving money. They end up having a better experience altogether with healthcare. And I see it over and over and over again. Patients will come and say, "You'll hardly ever see me. I never go to the doctor." And about 6 visits later, 2 months later, I'm going, "What was that?" "Oh, yeah, I've never been to the doctor this much." And I said, "You know what we did? We made it an experience that was worth going back. Because the reason you never went to the doctor was because you didn't want to have to schedule the appointment, wait for it, sit in the waiting room, sit longer, and get 7 minutes with somebody. And I was that person who gave 7 minutes, and I was left deflated just as much as you were." And that's how we're reshaping the experience of healthcare. But it begins with thinking. It begins with curiosity. And if you can't get somebody at least curious, you'll never fix anything. And that's where we need to leave them.
Folks, hope you've enjoyed this podcast. We've covered a lot of ground here in 50 plus minutes. Think about this and make the decision that is right for you. If you make the right one, we think you'll be very, very happy. Remember, behind every benefit, every policy, every decision, there's always a person. The question is simple. The answer decides everything. Did the patient win? This is Patients Win, where we'll keep asking until the answer is yes. For Dr. Bushman, for Troy Reichert, I'm Todd Miller. See you next time.